Now discussing about the etiopathogenesis, it is not very difficult to imagine that these patients who are having metabolic syndrome, this runs in the family. It has been observed that people who come from the Marwadi community or Baniya community or businessman community or people who are from the northern belt of the India, they are more prone to have metabolic syndrome. Obesity again runs in the... Obesity is also related with hypertension. People who take lot of sodium, people who take lot of salt, they are more prone to have hypertension. People who do less of the work, less involved in the physical activity, vigorous daily physical activity, they are more prone to have hypertension. People who take less of the fruits or vegetables, and by that way they take less of the potassium, they are more prone to have hypertension. People who take lot of alcohol, they are also more prone to have hypertension. But let me make it very clear, hypertension is not a single track phenomenon. It is a multifactorial problem in which the genes play, the obesity plays a role, the food habits take a role, smoking lifestyle also plays a role in the overall etiopathogenesis of the hypertension. Because of aging or because of certain other unknown reason, that is different story. But most of the time there is always a factor behind hypertension in the elderly. And we have discussed this problem of sodium insulin resistance syndrome, whether it is said that the hyperinsulinemia gives rise to sodium retention. It also gives rise to increased sympathetic activity. There is lot of vascular smooth muscle hypertrophy in patients who are having insulin resistance syndrome or metabolic syndrome. The cell membrane transport is also affected, and there might be some other pathways by which the insulin resistance syndrome might be leading to hypertension and coronary artery disease. Now let us dwell upon the clinical features of the hypertension. The hypertension, as I told you in the very beginning, may be completely asymptomatic in an individual. Only during a routine screening or LIC screening one comes to know that somebody is having hypertension. Or there is a bolt from the blue and then one regards the blood pressure is high. But sometimes the hypertension gives rise to certain classical symptoms. One of the classical symptom is headache. Usually whenever a patient in an elderly says that he has headache, please don't forget to record the blood pressure in an elderly. This should be a routine method, routine procedure, bedside procedure in an elderly who is coming with a headache. Or sometimes it comes with the target involvement. As I told you, when the heart is involved, there is a chance that he may come with the LVH, and thereby he may come with acute left ventricular failure, or he may come with the brain is involved, he may come with the stroke or various manifestations of the stroke, or coronary artery disease, or somebody may come with the advanced renal failure. And in the background of it, one comes to understand that he was perhaps hypertensive, and then it becomes a vicious cycle. Hypertension giving rise to kidney problem, and kidney problem again aggravating the hypertension. So this may be the classical clinical features of the hypertension. Now let us see how does it gives rise to certain signs in the system by which we recognize that the patient might be hypertensive. The pulse is forcible. Usually the pulse in an elderly, because of the loss of elasticity, because of the calcification in the arteries, the pulse may be forceful, the pulse may be rigid, and the arteries may be very, very thick and hard, what used to be called as a dancing brachial. Apex beat may be, because of the enlargement of the heart, apex beat might be shifted down and out. There may be second aortic sound may be increased. There may be click in the aortic region. There may be patient might be because having aortic regurgitation, features of aortic regurgitation, or sometimes you may listen AS4 gallop rhythm. And as I told you in my early part of the lecture, that these patients might be having signs of the hypertensive retinopathy. So one must have a look at the fundus and see what grade of hypertensive retinopathy this patient is having. And sometimes these patients may also come with the features of blood loss and severe epistaxis. A patient may come, hypertension may come with a severe epistaxis because it is a natural way of bringing down the blood pressure. And you regard the blood pressure is somewhere around 230 by 130. So again, a clinical dictum. In any case of epistaxis, one must regard the blood pressure. Patient may come with hematuria. Patient may come with hemoptysis, or a lady may come with metorrhagia. And so again, a dictum is, any lady who comes with metorrhagia, you have to regard the blood pressure and see whether the patient is hypertensive or not. Once you have decided that the patient is hypertensive or an elderly is hypertensive, you have to carry out certain investigation. And usual investigations are that you must look at the ECG and look for the left ventricular hypertrophy or coronary artery disease in these patients. Look at the urine. What does the urine show? What is the specific gravity of the urine? What is the route? Whether patient is having albumin, passing albumin. Whenever there is albuminuria in a patient of hypertension, the kidney disease has already started to take place. You must always look for the sugar, because a hypertensive may be diabetic, as I have told you. Look at the fasting blood sugar, carry out fasting blood sugar, and also do the 2-hour 75 gram glucose postprandial blood sugar investigation. Serum electrolyte, it gives you a lot of immense information about the status of the hypertension and the target organ involvement, serum sodium and serum potassium, the hematocrit. These are the simple investigations which can be carried out at any place. But there are certain special investigations which should also be carried out whenever you suspect hypertension in an elderly, depending upon the situation. Suppose a patient has come where you are suspecting dyslipidemia, you have to carry out the lipid investigations. In fact, in Western countries, the lipid investigation is a must in any case of the hypertension. You have to look at the creatinine. You have to take an X-ray chest, because X-ray chest will give you an idea about the cardiomegaly. X-ray will also give you an idea about the associated lung conditions, because most of these elderly who have been smoking in the past, they might be having COPD. And chronic obstructive pulmonary airway disease and hypertension is a very common problem. It's a very common presentation in an elderly. You have to look for the kidney size. For that you have to do ultrasonography. And this is important in the elderly because there may be hydronephrosis and because of the benign prostatic hypertrophy. So you have to look at the prostate also in a case of hypertension, and for that ultrasonography is a must. And some special investigation in a special situation is highly specific CRP estimation or homocysteine estimation in a case where there is a family history of premature coronary artery disease and hypertension. And having done these investigations, and let me dwell upon one very important investigation. This is ECG investigation showing LVH. Why it is important to look for the LVH? LVH is a very simple ECG sign which has immense value in hypertension, because risk of mortality, relative risk of mortality increases 1.5 times in men and 2 points in female. Women, for every 50 gram increase in the heart size, increase in the LVH, they are more prone to have coronary artery disease. People who have LVH are at increased risk of coronary artery disease, myocardial infarction, cerebrovascular accident, heart failure, and sudden coronary death. All this invaluable information, valuable signs of the prognosis can be assessed by just simple one measurement of LVH in the ECG. And this is, again, which is very important, LVH is reversible. This is if you give treatment to the persons in early stages of LVH, it is reversible. And LVH is independent of risk factors for cardiovascular mortality. And use of antihypertensive treatment leads to decrease in electrocardiographic LVH. And LVH, as I said, you can be diagnosed simply with the ECG. You see at the S wave in the V1 and R wave in the V5 or V6. If it is more than 35, then perhaps it indicates LVH. There are other criteria also. Now these days, with the advent of echocardiography, one can measure the echocardiographic LVH also. But in distant places where the facilities for echo are not there, ECG provides a very good yardstick for the LVH estimation. And next, we must also know that stroke, which is another very important complication of this hypertension, could be ischemic in nature, could be hemorrhagic in nature. Usually those people who have very high blood pressure, systolic blood pressure 240 and diastolic above 100, about 110, they are more prone to have hemorrhagic, or dementia, or microvascular infarct, or hypertensive encephalopathy. These are the 5 main presentations of stroke associated with hypertension in elderly. Hypertension again can involve the kidneys, and where the elderly could have chronic contracted kidney, have decreased glomerular filtration rates, or increased tubular dysfunction, and ultimately these patients may come to you with chronic renal failure. Then coming to the treatment, after having investigated the patient for target organ evaluation for the possible complication, we must treat the patient elderly hypertensive, and the goal of the treatment is bring down the blood pressure to 140/90, nearest the ideal blood pressure. But here is a matter of caution. In patients who have come to you, elderly patients who come to you with hypertension, severe hypertension and stroke, rather this goal is too ambitious. One should keep the blood pressure, systolic blood pressure in elderly with stroke around 160 and the diastolic blood pressure between 90 to 100. But those who have come with uncomplicated hypertension, without any manifest clinical signs of stroke or coronary artery disease, the goal of the blood pressure should be 140/90. And once you bring down the blood pressure to this ideal range, there is increased incidence of stroke, there is a decreased incidence of MI in 20 to 25% and decreased incidence of the heart failure. More than the 50% decrease could be noted once you lower down the blood pressure to a target goal of 140/90. This is the goal of the hypertension. Then lot of emphasis should be given on the therapeutic lifestyle changes in any case of hypertension, more so in cases where you are suspecting that the patient is having pre-hypertensive. The caution is that even if the elderly is having pre-hypertension, you have to advise him for this therapeutic lifestyle. And the advice is bring down the weight nearest to the ideal body mass index, somewhere around 22. The diet, there should be diet which should be having low sodium diet, which is about 2.4 grams of the sodium or 6 grams of the sodium chloride. You must encourage the elderly to do some physical activity. Go for an evening walk. Walk is one of the best exercise which can be advised to an elderly. Almost 5 days in a week, half an hour walk will be beneficial for an elderly. And in pre-hypertension, simple measures like weight reduction, diet, sodium restriction, physical activity, moderation in ethanol consumption, no more than 2 drinks. This is again very important, because higher the quantity of ethanol, higher the quantity of alcohol, more are the chances that the patient will have hypertension, coronary artery disease or stroke. And last but not the least is the yoga, transcendental meditation. This is one yogic exercise which is known as savasana. This is said to be very effective in bringing down the patients who are having pre-hypertension to the normal level, or those patients who are having stage 1 hypertension or stage 2 hypertension. The requirement of the antihypertensive treatment comes down significantly if somebody is doing yoga or somebody is doing yogic exercise and adopting the other lifestyle method of this. Having said so, now let me again touch another very important issue, which is the treatment, which is the best treatment for patients who are having hypertension. JNC 7 recommendations are absolutely clear that we must, as a first choice of treatment, is thiazide diuretics. This is the first preferred initial agent which should be given enough trial to patients who are having at least stage 1 hypertension without any manifest complication. But suppose if the patient has hypertension and the patient had myocardial infarction, of course then he has to be put on beta blocker. If the patient has diabetes or has shown proteinuria or had heart failure, or those patients who are having post myocardial infarction, that's ACE inhibitor, angiotensin converting enzyme 1 inhibitor, the choice of treatment is obviously thiazide plus angiotensin converting inhibitors. And of course in elderly, some newer type of the calcium channel blockers have also been advocated. Alpha blockers. Suppose the patient is having benign prostatic hypertrophy. This is very relevant for elderly population. Then alpha blockers, they become the choice of treatment in addition to thiazide diuretics. Patients who are smokers and it is becoming very difficult to control their smoking, then again, and they are hypertensive also, particularly elderly hypertensive, and then alpha blockers again become the choice of treatment in elderly hypertension. Then another aspect which we must remember in India while treating an Indian patient, there are certain very useful medicinal plants which are useful for elderly people. But before going to that, I will tell you what are the problems whenever we are treating patients with hypertension in elderly. Elderly people who are having hypertension, they have multiple problems. They have socio-economic problem in our country. Now more so in urban scenario. They have psychological problems. And you have to look into those problems also. Write such a drug, prescribe such lifestyle changes which are relevant to the socio-economic issues, relevant to the socio-economic background of a patient. And there is a misconception among elderly that the normal blood pressure in elderly is 100 plus A's. This misconception should completely be relieved from the mind of the elderly. There is another misperception in the elderly, that elderly have brittle hypertension, so we need not treat this hypertension. No, any elderly, as I said you at the beginning of my lecture, any elderly who has blood pressure of 140 or above, systolic blood pressure 140 or above, diastolic blood pressure 90 or above, he has got to be treated. This is a different matter, that you will start from therapeutic lifestyle, go on monitoring, and if the blood pressure comes down, you may not switch over to the therapeutic, you will not switch over to the pharmacological agents. This is a different matter, but this realization should be there. Any elderly who has 140 systolic blood pressure or above, 90 diastolic blood pressure above, he has got to be treated, he has got to be monitored, he has got to be investigated. And fourth point which one must remember, that elderly have variable blood pressure with exaggerated high and low extremes. So again, point of caution, whenever you prescribe drugs to the elderly, please monitor their blood pressure and take the blood pressure in, as I said in the beginning, in the sitting position as well as in the standing position to rule out the possibility of postural hypertension. Now let me tell about this useful medicinal plant which we have plenty in our surroundings and which could be useful particularly in patients who are having pre-hypertension, particularly in patients who are having hypertension and coronary artery disease, particularly in patients who are having hypertension and dyslipidemia. These plants are, one of the plant is called T. Arjuna, which is popularly known as Arjuna. Its bark stem powder is useful for hypertension. It is diuretic. It is useful for coronary artery disease. Another popular plant is Imblica officinalis, which is popularly known as gooseberry or amla. This is again having lot of antioxidant material. This is having lot of potassium. So this is also said to be useful in cases of hypertension. The third plant which comes to my mind is Ocimum sanctum, which is known as tulsi. Its leaves are also having lot of bioflavonoids, and it is also said to be useful in cases of hypertension and coronary artery disease. And the last is Withenia somnifera, which is popularly known as ashwagandha. This is said to be immunomodulating agent. This is also considered to be useful in dementia. So elderly people who are having hypertension, I think one can suggest these drugs. These are folk remedies, and these could be suggested as adjuvant drugs to the people who are having hypertension. And one of the useful asana, which is called savasana. This should also be told to the patient. Savasana is a very simple exercise which can be done by every individual at any age with any complication. Even patients who are having myocardial infarction and convalescing, or patients who have undergone bypass surgery, they can be told to practice savasana at home. This is just for 10 to 15 minutes every day, twice in a day, and that also brings down at least the people brings down the pre-hypertension to normal blood pressure. These are all the points which I had to tell you about hypertension while dealing in elderly population.
Dr. Madhu, will you like to highlight few important points on hypertension, or you would like to add something to his?
No, I think Dr. Dwivedi has covered the topic quite well and quite comprehensively. The important focus that I want to stress is that, as has been stressed already, that hypertension never exists alone, and it is associated with several comorbidities. In fact, elderly hypertensives, elderly diabetics, elderly coronary artery disease patients, all of them come together, and all these problems exist in one patient. And in fact, patients who are taking antihypertensive drugs would also be having prescriptions for CAD as well as for diabetes mellitus, and therefore one has to carefully structure the prescription of these patients so that there is no interaction between the drugs used for one condition with drugs used for another condition, and the prescription doesn't become too large, and it's manageable, and the elderly patient complies with the treatment that is offered.
Yeah. Dr. Dwivedi, maybe few tips, as you highlighted that medicinal plants. You also told that in the early stage of the hypertension, the LVH can be reversible. Like this, if you want to give some tips, maybe in 1-2 minutes.
I think it's very important whenever you come across an elderly, please record the blood pressure. This is the first thing which is very important, because blood pressure can manifest, can affect most of the system of the body. So recording blood pressure is very important. And whenever you find that this patient is having hypertension, please record the blood pressure standing and sitting both, to rule out postural hypertension. And once you have seen that the patient is having hypertension, please examine this patient very carefully. The heart should be examined, and signs of the cardiomegaly and the signs of left ventricular failure should be looked for specifically. Look at his fundus and try to rule out whether he has hypertensive retinopathy or not, and then do the complete CNS examination just to rule out any possible evidence of the stroke. Having decided so, please carry out very simple investigations like urine, like ECG, to rule out whether he has silent coronary artery disease, whether he has manifest coronary artery disease, whether he has any signs of the LVH. This is very simple. Do the X-ray test, look for the cardiomegaly, look for the signs of the COPD, and then look for the urine. In the urine, look for the albumin, look for the sugar. Having done this basic homework, then perhaps you can always think of the situation, the comorbid conditions which this patient might be having, and then you can switch him over to the drugs. And most important of all the drugs is therapeutic lifestyle. You will have to impress upon the patient that he should not smoke, he should go for the walk, His diet should not be containing lot of fat, lot of salt, and then put him on very simple drugs like thiazide diuretic. And of course, if there are comorbid conditions like diabetes, like coronary artery disease, like COPD, you have to add one drugs for these conditions also, so that he goes home with all the basic drugs for all the basic problems which he is having, and impress upon him that he has to come for checkup, for his preventive checkup almost every 3 weekly or so, and get the blood pressure examined every 3 weekly.
Thank you. Thank you, Dr. Dwivedi. Thank you all.